Thank you, Dr. Ghazi, for the nice introduction, and thanks, Dr. Ahmed and the organizing committee for the invitation. In 4 years, I will not have more grandchildren. So what I'll try to cover in this 25 minutes are the following. I'll talk about rituximab in newly diagnosed Ph-negative ALL. I'll talk about newly diagnosed Ph-negative ALL and where novel therapy plays a role. Older patients with Ph-negative ALL and Ph-positive ALL, where novel therapy plays the role there. And I will focus on the upfront therapy. So rituximab, although rituximab is not novel, but it's an important, and there's some few learning points by discussing the data. This is the study that probably most of us would know. The question of that study, if you add rituximab to CD20 positive ALL at 20% on flow, whether this would have an impact on the event-free survival or the overall survival. So that platform is similar to the UCAL. What they did, they add 2 rituximab infusions with every intensive block of the protocol, and few in the maintenance, for a total of about 16 to 18 cycles of rituximab or infusions of rituximab. And look at the results. So the first result is that the rituximab group had a better event-free survival. The event-free survival was improved from 43 to 55%, which was statistically significant. If you look at the relapse rate, this is the relapse. So the relapse has decreased by adding rituximab from 41% to 25%, which is again was statistically significant. And that reduction in relapse and improvement in event-free survival led to, numerically, at least in that study, where the survival has improved from 50% to 61% in that study. Now, the p-value is 0.1, which means it's not statistically significant. So whether this is unpowered but the trend is clearly there. So that was the first study, and most of us adopted adding rituximab. Now, how many infusions? That's the question. Now, if you look at the other study that investigated the addition of rituximab to the regimen is the UCAL14. And what UCAL14 did is adding only 4 doses of rituximab, 4 weekly doses of rituximab during the induction period. This was a very big study, over 800 patients. So if the general study missed the overall survival because of unpower, you should see it here. And the results, unfortunately, the event-free survival, although numerically was better in the rituximab group, the difference was not statistically significant. If you look at the hazard ratio, it's about 0.88, so that means 12% reduction in the events. And so it was, the conclusion, it was not statistically significant. However, when you look at the group that underwent myeloablative stem cell transplant, you see that the rituximab group did better compared to the standard of care group. And the effect size is hazard ratio of 0.47, so at least 50% reduction in the risk in the probability of events if you add rituximab. And to add to it, if you look, these are not a randomized comparison, these are subgroup analysis, and the rituximab group was prognostically worse than the standard of care. So that group was supposed to do worse. So the conclusion here, if you use rituximab, use 16 to 18 doses, especially in those who have higher risk disease that you plan to send for transplant. So that's the rituximab messages. The second is the newly diagnosed Ph-negative ALL in all age groups. So that study, the E1910 study, it asked that question, whether you consolidate with novel therapy versus if you consolidate with a standard chemo. So the study included Ph-negative patients who had a BFM induction followed by intensification. And after intensification, the stratification here is by the MRD. So if it was MRD positive, because now it's standard of care that you give blinatumomab for the MRD positive, these were removed later, and they randomized patients who are MRD negative. They were randomized to consolidation with blinatumomab versus standard chemotherapy. And the consolidation of blinatumomab, they had like 4 cycles of blinatumomab. They started with 2 cycles, then 2 cycles of blina, 3 cycles of chemo, 1 cycle of plasma, 1 cycle of chemo, and then 1 cycle of blina. So a total of 4 doses of blinatumomab. And then the maintenance is a standard pump maintenance. So now with adding blina to the consolidation therapy would make an impact or not. And these are the results. The CR rate overall was 81%, and most of this overall CR is in complete CR, is 75%. If you look at the MRD after intensification, 78% achieved MRD negative, even before receiving the blinatumomab. So those were randomized with the blina consolidation. And you look at the results. So these are again baseline characteristics. Almost 20% of patients in each group underwent bone marrow transplant. Results. This is the top curve, is the curve with blinatumomab consolidation, and the lower curve is chemotherapy. It's clearly separating early and clinically significant separation. If you look at the overall survival at 3.6 years, it was 83% for the blina consolidation versus 65% for the chemotherapy consolidation. And if you look at the hazard ratio, is 0.4. Almost 60% reduction in death if you add blinatumomab to the group, if you consolidate with blinatumomab. So that's, I think one of the major things in the management of patients with pH-negative ALL. Now, the second question is, okay, go to MD Anderson where what they did, they looked at the addition of blinatumomab to the hyper-CVAD protocol. And what they did, after some time, they amended it with adding inotuzumab. So the question is now, you try to, beside the standard chemo, adding blina and adding inotuzumab. So they get 4 alternating cycles of chemo, and then they added 2 inotuzumab cycles in the 2 cycles of the chemotherapy. 4 cycles of blinatumomab, again, they added 2 cycles of inotuzumab here. And during the pump maintenance, they gave 3 cycles of blinatumomab, a lot of blinatumomab. And what they did now is to compare the cohort that received hyper-CVAD blina versus the later cohort that received hyper-CVAD blinatumomab and inotuzumab. And these are the results. Now, this is not randomized clinical trial, 2 cohorts, and there are significant baseline differences, clinically significant baseline differences between the 2 groups. This is the group that received the hyper-CVAD and blina, and the last one is the hyper-CVAD blina inotuzumab. Age, older in the blina group. If you look at the prognostic impact, TP53 mutation were higher in this group. CRLF2 were higher also in this group, and bad cytogenetics were also higher in the hyper-CVAD blina group. Look at the result. The rate of CR, almost 80 to 90% in all groups. So again, very high rate of CR. And then when you look at the MRD, you look at the MRD by flow, 97% in the hyper-CVAD, blina, 88% in the hyper-CVAD, blina, inotuzumab combination. So you don't see like a big difference. Actually, you see like this is lower than this. But if you look at the NGS MRD negativity, you see that patients had higher MRD negativity rate if you do it by the NGS versus 50%, so 72% versus 50%. So that conclude maybe now adding INO, BLINA to hyper-CVAD does improve the rate of negativity. That's probably because of maybe non-specific positivities in the flow, but that's one of the explanation for that discrepancy. We know that this is true, that the MRD is negative by looking at the clinical outcomes. So if you look at the clinical outcomes and you look at the relapse-free survival, you see that the group that got the 3 had numerically better than the group that had the 2, although it was not statistically significant, but it is 92% versus 76%. If you look at the overall survival, it was statistically significant. So 100% of patients who got the 3 had overall survival, but the probability was 84% for the group that got the hyper-CVAD BLINA. So maybe if you add now inotuzumab to hyper-CVAD BLINA, if you use hyper-CVAD BLINA, it does improve the survival in this group. Now we shift to the older patients with Ph-negative ALL. This is a protocol that we heavily use in relapse refractory ALL, and I think many of us are using here. This is mini hyper-CVAD, the CVD with the addition of the inotuzumab after capping the inotuzumab to 2.7. But this now take it from the relapse refractory and give it to the older patients who are Ph-negative ALL. And these are the results. The overall response rate is 98% and the CR is 85%. Again, high numbers, consistent with the previous incorporation of novel therapy in the management. The rate of VOD was 8%, which is not a small rate. Actually, 2 of the fatal cases were in the INO group, but the group that got the higher dose of inotuzumab before capping it to 2.7. And these are the outcomes. This is the 2 curves of overall survival and event-free survival. And if you can, if you see that the median progression-free survival was 35 months, and if you look at the numbers, let's say at 3 years, it's about 50 to 60% overall survival, event-free survival. So historically, this group did really that way, which is historically it was much worse than these numbers. Although these numbers are still in the 50, 60, but they're way better than the historic data in that age group. So maybe now if you apply this, if you take it from relapse refractory for older patients, that's one of the way that incorporation of novel therapy improves outcomes. The other approach is, okay, we should not depend on chemo, we just on novel therapies. And that study examines that approach, combination of inotuzumab with blinatumomab. So Ph-negative in older Ph-negative ALL patients, induction with inotuzumab at a dose of 1.8. And then if they are in CR, you add another cycle of inotuzumab at a smaller dose. And then you give 2 more cycles of blinatumomab. Now, if they are not in CR, they would not give a second cycle of INO, and they would go to BLINA and add 1 more cycle. So they would give 3 cycles of blinatumomab. And because of these medications they don't cross the blood-brain barrier, and they incorporated 8 cycles of IT, so you don't need to use the 33 grams of methotrexate. So these are the responses. The CR rates, composite CR 85 after inotuzumab induction and 97% after INO BLINA. This is only novel therapies, INO BLINA. And if you look at the overall survival, at least now, 1 year overall survival and event-free survival in the range of 75 and 85%, which is very good. Although when you look at the curves continue to go down. So maybe, again, it's not curative, but at least the effect of toxicity and the 1 year, so far 1 year event-free survival and overall survival are reasonable for that age group. So that's the combination. The last thing I'll speak about is the Ph-positive ALL. And the first thing I'll start is with the maybe time sequence. So forgetting about the traditional way of treating pH-positive ALL, standard chemo protocol, and adding tyrosine kinase inhibitor, this study, called Total Therapy Sequential Strategy, the initial Italian approach, what they did, they took the pH-positive ALL patients and they induced them with dasatinib steroids. The steroids were started pre-phase and then continued for about 4 weeks. And then the dasatinib was given at 140 milligram per day for a total of 3 months, about 12 weeks. The post-induction, then this is where they gave the chemotherapy. So they continued dasatinib and 2 cycles of consolidation using clofarabine and cyclophosphamide. 5 days for the first cycle, and then 3 days for the second cycle. And they continued using the dasatinib. By the end of the induction, the complete hematological response was 97%. And if you look at the disease-free survival and the overall survival for this group, around 50% at long-term follow-up. At 5 years, 47%. So again, reasonable numbers for taking the induction mortality. One of the things that we clearly felt after we adopted this in Oman, that induction mortality has significantly decreased for the pH-positive ALL. Now, a further improvement to this is the dasatinib-blina approach, the D-ALBA. So what they did in that study, they used the same induction, dasatinib steroids, but instead of the chemo consolidation, they give blina consolidation. So they gave a maximum of 4 or 5 cycles of the blinatumomab, of course, with the dasatinib. Now, look at the responses, the overall molecular responses. So the responses improved from 17% at day 22 to almost 80% after the 4th cycle of blinatumomab. And this 81%, if you look at the complete molecular response, it's almost 50%. And when you look at the clinical outcomes in terms of the overall survival and disease-free survival, the numbers were very good. Again, relatively short follow-up at 14.3 months, median follow-up, 95% overall survival, and 90% disease-free survival. So again, incorporation of blinatumomab consolidation has a major impact on the outcomes here. Now, the next maybe improvement is to use a stronger tyrosine kinase inhibitor, ponatinib, and instead of using steroids with the induction, you use the blinatumomab with the induction. So in that study, they gave ponatinib at 30 milligram combined with blinatumomab as induction. And then the consolidation part was ponatinib 30 reduced to 50 if complete molecular response was achieved, and completing the blinatumomab. And then maintenance with only ponatinib at 30 or 15 milligram. Results, again, ITs, 12 to 15 ITs were incorporated into the results, into the protocol. CR/CRI rates, 98%, very good. Complete molecular response, 84%. And if you look at the overall survival and event-free survival at 2 years, almost 90% overall survival and 80% event-free survival. So relatively higher rates of survival. So at the end, in summary, patients, rituximab improves event-free survival, especially when given in 16 to 18 doses, and in patients undergoing hematopoietic stem cell transplants. Consolidation with blinatumomab improves overall survival in newly diagnosed pH-negative ALL. Chemo-blina-INO combination decreases relapse and improves overall survival in newly diagnosed pH-negative ALL. Chemo-free approach, INO-blina, gives higher rates of CRs and reasonable 1-year event-free survival and overall survival in older patients with pH-negative ALL. And TKI-blina in pH-positive ALL results in high rates of remission and long-term disease-free survival and overall survival. And with that, I would like to thank you for listening.